Hello everyone. Now I'll discuss question of respiratory system. So we have a 50-year-old man brought to you by his wife. According to her, he wakes up at night repeatedly with a choking sensation, but is able to fall back asleep quickly. Well, he reports fatigue that he often falls asleep while reading books or watching television in the daytime. He had a childhood history of asthma and required inhaler. Now he has problem of type 2 diabetes, hyperlipidemia, hypertension. And at the moment, the patient is taking metformin for diabetes, sitagliptin for diabetes, atorvastatin for lipid, amlodipine and lisinopril for hypertension. And BP at the moment is still high. And BMI 34 is very, very high. And there is no jugular venous distension. That means there is no heart failure. Lungs are clear on auscultation. Again indicate there is no lung pathology as of now. We are getting a 2/6 apical hollow systolic murmur. There is no organomegaly. Bilateral mild edema is there. What is the most likely cause of this patient's symptom? Well, the answer to this question is intermittent upper airway collapse. Well, this patient has several classical findings of obstructive sleep apnea, and where there is intermittent upper airway collapse is there. This causes nocturnal hypoventilation. He wakes up at night repeatedly, the choking sensation, but is able to fall asleep quickly. That problem that we saw, the patient has. So we could understand why the problem is of nocturnal hypoventilation is because of the problem patient has. OSA results from laxity of the pharyngeal musculature, leading to transient upper way obstruction in the reduced consciousness setting of sleep. Okay. Well, before I proceed further, I like to tell you something very, very important. As we say the patient lying supine, the tongue goes backward and lead to airway obstruction or due to pharyngeal collapse is there. They all contribute to airway obstruction at the level of throat only. That's why these patients are always advised to go for prone position sleep. It is one of the very simple, very effective method of preventing the collapse, or other a patient come to you. These patients should always be advised for prone positioning. Now let me tell you anatomy, what the problem is. Look into this normal airway. First we see the normal airway. This is the tongue, this is the tongue, and this the air is coming like this. Now what happened in these patients? Look into this. Look into this. This is a tongue and soft tissue, soft palate. They are blocking the airways. You can see the air is able not, it comes here, but airway is blocked. And that's why patient has severe hypoxia, he is breathing difficulty, and he will get up. He will get up in a semi-conscious state, the way I'm looking to you like this thing. He will bend forward, again tongue will fall forward, the airway will open, again he will sleep, same problem. He has to get up many times at night so that sleep is disturbed. Well, if I have to give to you a day-to-day example, we being medicos, we do night duties. It will happen at night. It's a very heavy night, emergency, lots of patients, and whole night you are awake. What happened to you in the morning? This is what is happening to this gentleman daily. What happened to us? We are fatigued, we are sleepy, we have no energy, we want to sleep immediately, we don't want any disturbance. And if due to any reason we are not able to sleep in the daytime, we are irritated. And of course, it's only a matter of one day, but this gentleman having problem for the whole life. That means, imagine, you can magnify the problem, what you must have experienced. Your is a physiological disturbance, this is a pathological disturbance, day-to-day example. So now, but one thing is there, in comparison to central sleep apnea, the respiratory drive remains intact. And because we have central sleep apnea where the respiratory drive is not there. Now, what are typical manifestations of OSA? Something I mentioned. Excessive daytime sleepiness, where like our patient falls while reading books or watching TV. Morning headache, impotence, poor judgment, and depression are all additional because his work efficiency goes down drastically. A history of snoring and period of apnea or gagging witnessed by bed partner is often reported. Like our patient, according to her wife, he wakes up at night repeatedly with a choking sensation but is able to fall asleep quickly. That's the point which really goes in favor of OSA. Examination is remarkable for obesity. Our patient has BMI of 34, very obese, increased neck girth, systemic hypertension there. Right now, although patient is taking lisinopril or amlodipine, but still his BP is 170/100. Okay. Now let's look into other option. Airway inflammation and hyperresponsiveness. This is classically seen in reactive airway disease and the common cause of cough and dyspnea. Of course, because this patient has a childhood of history of asthma, but there is no evidence of ongoing RAD. RAD is usually we use the term a type of bronchial asthma. No wheeze, no cough. Lungs are clear on auscultation. So reactive airway disease, also called bronchial asthma, is not a problem here, although he had a childhood asthma. What about option B, aspiration of gastric content? Is that this happen in GERD, which can cause nighttime cough? Is a well-known cause. In GERD, reflex symptom, burning, epigastric pain should be there, which are not there in our case. And this will not explain the patient daytime fatigue. Okay, this will not explained by GERD. What about option C, increased alveolar arterial oxygen gradient? OSA hypoventilation occur, but this does not cause increase in alveolar arterial gradient. And this increase, what we call as PaO2 and PaO2. This is alveolus, this is arteriolar. This gradient occurs in the setting of right to left shunt. VQ mismatch like pulmonary embolism, pneumonia, ARDS. Inspired gas exchange, interstitial lung disease. A few examples where the gradient is increased. Now again, I have a question for you. I just give you example in ARDS. This gradient increases. Now stop the video, write down the answer. What is the basic mechanism or why this increased alveolar gradient occurs in the setting of ARDS? Stop the video, write down the answer in your copy. Well, let's learn the basic of ARDS. In ARDS, this is the alveolus. And the oxygen which comes here is PaO2, which come from the air. This is the arteriole. This is the arteriole. Okay. And the oxygen is PaO2. PaO2. Now, normally, oxygen goes like this and CO2 comes like this. Now, in ARDS, this is the interstitium. In the interstitium, a protein-rich fluid accumulates. This is the protein-rich fluid is there. Well, this whole interstitium becomes stiff. That's why ARDS is also known as stiff lung, because interstitium is full of liquid. Now we know that oxygen is a water insoluble gas. So oxygen cannot go in. So that means this PaO2 will be high and this will remain low. Why low? Because oxygen is not coming in. So gradient will increase. But CO2 is a water soluble gas. It can go out. So net result will be there will be hypoxia and hypocarbia. So this will lead to type 1 failure. And in this case, PaO2 gradient will increase. The reason I told you. Okay, let's look into option E, pulmonary vascular congestion. This occurs from heart failure. It can lead to disturbed sleep, PND, paroxysmal nocturnal dyspnea. However, other than mild lower extremity edema, possibly maybe due to amlodipine, but there is no other feature which is suggestive of pulmonary vascular congestion. And moreover, in PND, we don't get it. This choking sensation, getting again sleeping immediately is not the feature. Patient has no JV distension and crackles. That again rules out heart failure. Holosystolic murmur suggests mild mitral regurgitation, which is unlikely to cause pulmonary venous congestion. The fact he can fall back asleep quickly after experiencing choking sensation is more consistent with OSA. In fact, this finding is the one which definitely rules out congestive heart failure. Well, a quick recap of the last revision point: obstructive sleep apnea, OSA. Basic pathophysiology is relaxation of pharyngeal muscle lead to closure of airways, loud snoring with period of apnea. The symptom: daytime sleepiness, non-restorative sleep with frequent awakening, morning headache, affective and cognitive symptoms. Sequelae: systemic hypertension, pulmonary hypertension with right heart failure. The golden line to remember: obstructive sleep apnea is a condition caused by transient obstruction to upper airway due to laxity of pharyngeal tissue, resulting in nocturnal hypoventilation. The main features are daytime sleepiness, snoring, and brief choking or gagging sensation while sleeping. Thank you very much.